Hi, it's Jonathan,
Hi, Amy.
and welcome to Cats in the Case. And Amy, how have you been?
Yeah, not too bad. What about you?
Yeah, pretty good, pretty good.
Yeah.
Seen any good stuff?
No, nothing ever interesting happens when I'm on shift.
Nothing. Well, I tell you
No,
what,
what
I
about
had
you?
something very interesting, and it was an ultrasound case.
Oh, okay.
But I'm afraid to say, I think ultrasound let me down, Amy.
No.
No, it did. It seriously let me down. So let me just paint the picture, okay? So we've got this 35-year-old woman. She's come in, stabbed in the right upper quadrant. Okay,
Right,
so
yeah.
team's ready, stabbed in the right upper quadrant, and she sounds pretty unwell. And in fact, she looks pretty unwell when she comes in. So she's got a heart rate of 120. She's got a blood pressure of 95. She's in pain, and lo and behold, she's got a stab wound to kind of right upper quadrant, lower ribs. That's this sort of area. This is where she's stabbed.
Okay.
I examine her chest, no pneumothorax. It looks okay. Tummy's tender. What am I thinking? I'm thinking ultrasound's going to help me. I'm thinking I'm going to get a positive fast, right? I mean, this is going to be a positive fast.
Yeah.
So I do that, and guess what?
There was blood and more since back.
There's no blood at all.
Okay.
I can't see blood at all. So I've got this woman who's hemodynamically unstable. She should have a positive fast. It's negative, and I've got surgeons and teams down there going, well, actually, maybe it's not as bad as you think, but it's bad. Clinically, this person, I mean, she hasn't got evisceration. She hasn't got, guts on view or stuff, but she should have fluid in Morrison's pouch. She should have a positive fast. What the hell's going on, Amy?
Right, so it sounds like you still suspect that she's bleeding, but the ultrasound isn't helping with that.
It's let me down.
Okay. So, I mean, did she get a CT after, or what was the next thing that you did?
Well, she got a CT because obviously we weren't going to theatre in a hurry. But I tell you, if the fast was positive, I probably would have.
Right.
Because my understanding, and correct me if I'm wrong, I mean, the utility of ultrasound in this situation is to help me work out whether someone should go straight to theatre or not. Yeah, okay. But I've got a question for you. Yeah. Is that the case for penetrating trauma to the abdomen? Is it the same? Am I extrapolating, blunt and penetrating?
Well, I think it's less sensitive. The utility of fast is less sensitive for penetrating versus blunt trauma.
Yeah, okay.
And I think that's just because of the presence of air. So as soon as air gets in the picture, ultrasound images are a lot less accurate.
I've wondered about that.
Yeah, I think that was maybe the case with your patient?
Although no pneumothorax, no subcutaneous. You're just talking normal, just any air?
Yeah, so any air in the tissue that's, subcutaneous will be enough to reduce.
Okay, so you're saying in penetrating abdominal trauma, the fast is what? How sensitive are we talking?
I think numbers say things like anywhere from 20 to 80%. So it's
Cochrane Review 2011, anywhere between 28 and 100% sensitivity. They're talking about. That's pretty.
Variation.
That's a pretty big variation. Well, what's been your experience? Is it accurate? Is it not? Should I rely on it, Amy?
Well, I think when it comes to penetrating trauma, it's a bit different. So. If it's negative, it's still going to need more investigation, right? So you did the right thing. You might get CT. Sometimes you might need explorative laparoscopy, laparotomy, and also with penetrating trauma, there are a lot of bowel injuries involved, which you can't see in a fast.
So I won't see that on the fast. And let's face it, the fast is only going to tell me that there's fluid, right? The fast is not going to tell me about actual organ injuries.
Correct.
So there might be a injury to the liver. The fast is not going to tell me that. Like it'll tell me the result of the injury to the liver. Have they bled around it? But it's not going to give me the detail I need. So I'm going to need a CT anyway.
Yeah. The patient's stable enough.
Yeah. We went to CT, right? And this is the kicker. We go to CT. There's blood everywhere.
Right.
There's blood.
Where?
Yeah. Well, actually, this is the thing. Well, let's have a look.
Are you just showing me one slice?
That's all you get on the fast. One view of Morrison's pouch.
No, it's not, and that can be part of the issue. Remember that we need to target the whole right upper quadrant area, Morrison's subphrenic area, and the paracolic gutter.
Sure.
So the CT does show lots of blood, which is interestingly in the subphrenic space and none in Morrison's pouch.
I'll show you the ultrasound. Here's my ultrasound, right? Okay. Here's the ultrasound. Here's Morrison's pouch. So I've come back from CT and they've said there's blood, right? Here's my ultrasound. Where's the blood?
All right, so I can
There's
see
no
there.
blood.
Yeah, so we've got Morrison's pouch looks pretty empty. Did you have a good look at the paracolic gutter as well? Tip of the liver?
Probably.
Okay, and that
Yeah.
was negative?
Yeah, that was like the tip. Yeah.
Yeah, the tip.
Yeah, okay. I
And
did,
that's
yes.
normally where the fluid starts and
Yes.
drains into Morrison's. And what about sort of subphrenic space, so that's space between the diaphragm and the liver?
Yeah, I think that was probably the issue.
Right.
Yeah.
That's where the blood
Yeah.
was hiding.
So I looked, I mean, my technique, I look in Morrison's pouch, I'll go to the other side,
Mhm.
I'll go to the pelvis, and I'll go pericardial view through
Yeah.
the tamponade.
And look, you're right, because that's normally where fluid drains in penetrating trauma, well, in any abdominal trauma.
Yep.
So it's the right quadrant is most sensitive for positive fast.
Yep. So that's where I start.
Yeah,
Yeah,
and that's
yeah.
you're right in starting that. So
Yeah.
this is a really tricky and unusual case that the blood was not Morrison's pouch, but it was actually subphrenic.
Yeah, okay. And I guess that's the thing. So not only is it less sensitive, but because it's penetrating trauma, maybe the blood may accumulate somewhere surprising.
Yeah, potentially. Or else I was just actually thinking that, you know, what could have obscured your view is, number one, the air that we talked about. So ultrasound doesn't like air. So if there's air in the picture, then you're not going to get good views. Secondly, the area where the patient was stabbed, in between the ribs, so some rib shadowing might have caused.
Yes.
You know, you might not have
it was
done
uncomfortable.
that.
No, it was. Yeah, it was very, it's awkward. You know, here she is in pain, and I've gone and stuck the probe exactly where it hurts, right?
Yeah.
So I can't really press very hard. I can't really get a great picture. So that'll make it less accurate as well.
Yeah. So what you can do is, if you think that the rib shadows are obscuring your view, you can either just rotate sort of slightly counterclockwise to go along the angle of the rib,
Okay.
or else you can actually change your probe to phase array just for a smaller footprint to look in between the ribs.
Phase array. Which one's that?
That's a cardiac probe.
Yeah, okay, so go to cardiac probe. All right. So, well, that's a few good tips and tricks. So do you reckon, let me put it to you, if you had seen that negative fast, the negative Morrison's pouch, what would you have done? Would you have...
I think I would have done the same as you. So it sounds like it was a very unusual case that the blood wasn't there. And you did the right thing going to CT, and it sounds like she did okay in the end.
Yeah, she did fine. I mean, actually, it was... she did fine. She needed exploration because there were issues about other structures damaged. So, you know, diaphragm injury. Had to have a look at liver. So I mean, that was just an interesting case. It's a case where I thought I was pretty good with fast, but it's kind of let me down. But actually, it probably didn't. I was pushing it to its limitations.
Yeah, I think it's not perfect, and all imaging modalities have their own pitfalls. So good thing to keep in mind.
Yeah. So in summary, there's a wide range of sensitivities with fast in penetrating trauma. Yeah. Make sure you interrogate that Morrison's pouch view properly. It's still good to start there.
Yeah.
Be aware of the pitfalls, so rib shadowing. Sometimes the blood can accumulate somewhere else. And probably, if you don't have ready access to a CT scan, a bit of time and repeat it.
Serial exams.
Yeah, serial exams. All right.
It might
Thanks,
seem
Amy.
crazy,
That's great.
but I'm about to
Okay,
say.
all right. We'll see you next time. Bye.
Bye.